Hello, I am Melissa Meisenbacher, board member of the International 22q11.2 Deletion Foundation. Today we will be hearing from Julie Moldenhauer, Director of Obstetrical Services, Medical Director of the Special Delivery Unit at the Center for Fetal Diagnosis and Treatment at the Children's Hospital of Philadelphia. She is also the Associate Professor of Clinical Obstetrics and Gynecology and Surgery at the Perelman School of Medicine at the University of Pennsylvania. We will also hear from Erica Schindewolf, Genetic Counselor at the Center for Fetal Diagnosis and Treatment at the Children's Hospital of Philadelphia. Thank you, Julie and Erica.
Thank you.
Good afternoon. We will be discussing the prenatal medical management of 22q11.2 deletion syndrome, tips for families. We acknowledge that the majority of this audience are probably parents whose children are affected with 22q. And so some of these prenatal findings and tips may be more appropriate for individuals who are currently pregnant or who are, like many of us, advocating for families who have not yet been diagnosed or for medical providers within their area. But we hope that you can take away some interesting tips about what pregnancy is like for people who are going through a diagnosis or what to look for in pregnancy as we continue to do our advocate work. And so as many people know, 22q11.2 deletion syndrome is the most common microdeletion syndrome. It affects 1 in 2,000 to 1 in 6,000 live births, and in some studies have been shown in 1 in 1,000 fetuses without structural cardiac differences. We all can appreciate how under-recognized this condition is in the prenatal and postnatal period, and this is largely due to the wide clinical variability of 22q. And our hope is that we increase awareness of what this condition can look like prenatally and postnatally, and we increase testing options so that we can really shed light on the incidence and spectrum of the condition and increase outcomes for our kids. For individuals who are pregnant, it's important to know what options exist in terms of screening for this condition. And there are many options, whether that be preconception, so an individual has a family member with 22q or a prior child with 22q, or they themselves have 22q. First trimester with ultrasound imaging, genetic counseling, and screening, and second trimester with imaging and diagnostic or screening tests. And we'll go through, based on trimester, what options can be available to families and how to best access those options. So as early as 10 weeks, an individual who is pregnant can be offered screening for 22q. And that is typically in the form of non-invasive prenatal screening, which is also called cell-free DNA testing. And this is a blood test on a pregnant woman and can occur anytime after 10 weeks gestation. And what this test looks for is evaluates mom's blood and can look at small fragments of the placenta that is circulating through mom's blood. And so as the placenta grows with mom and with the baby, there are small fragments of placental DNA that are making its way through mom's bloodstream. And many of our commercial labs can then identify what is mom's DNA and what is placental DNA and go through different processes to look for increased risk of common chromosomal conditions. This test was initially developed to look for chromosomal conditions such as Down syndrome or trisomy 21, trisomy 13, and trisomy 18. And then evolved to look for sex chromosome differences such as X and Y differences, and then has expanded to look for microdeletion conditions such as 22q. Results typically take 10 to 14 days to complete and provide individuals with a risk of high risk or low risk for these conditions. There have been many studies to look at the utility of using this testing for microdeletion syndrome. And most recently, a study was performed in 2018 that looked at about 350 individuals that were identified to have microdeletion syndromes off of non-invasive prenatal screening. And interestingly, only 32 of those individuals had diagnostic testing that confirmed the result, which yields that the test was positive or really could predict that condition in only about 9% of the cases they saw. A large majority of this cohort screened positive for 22q, but only 12 were confirmed to have 22q based on diagnostic testing. There have been other studies that look at these same variables, and they saw a slightly higher positive predictive value, but still medical providers pose this as a screening test for this condition and not a diagnostic test. And the reason for this is, one, the DNA is coming from the placenta, and so there are a small percentage of times where placental DNA will actually be different than baby's DNA. Additionally, the screening test looks for the most common deletion, the A to D deletion, and so could miss some of the atypical deletions that many of our kids have. And also, it's just not a diagnostic test at this time. So certainly a positive result on this test gives an indication to look more closely, but a negative result on this test does not mean that the child is affected or unaffected with this condition. Many individuals can also have prenatal diagnostic testing around the same time in gestation, after 10 weeks, between 10 and 13 weeks gestation, and that is through something called chorionic villus sampling, or CVS testing. And this is a test in which a placental biopsy is obtained, either transvaginally or transabdominally, and the placental DNA can then be tested via a microarray for 22q. Prenatal testing such as CVS does confer with a risk, and that risk is somewhat dependent on the center's experience, so certainly something we should always be asking our families to ask their providers about. But the most recent reports have reported miscarriage rates of about 0.22%. Some of the other risks that can be associated with this procedure are Rh sensitization, congenital infection, and then the results of something called confined placental mosaicism, which we briefly touched on, meaning that the CVS results would be related to baby's placental DNA and may not be reflective of the fetus. We'll now move into the second trimester, where we focus most on screening modalities of echocardiogram and ultrasound. And certainly ultrasound is offered to women in the first trimester and usually looks at that back of the baby's neck measurement to determine if that is increased. That's something called the nuchal fold. And if that is increased, then that can also be a referral to something like a fetal echocardiogram, which we'll talk about, or to a maternal-fetal medicine provider who may offer the test that we just went over. Cardiac associations, as we all know, remain the most well-described association with 22q. In our most recent paper, 95% of fetuses were affected with heart disease. And in Dr. Campbell's paper published in 2018, 64% of the pediatric cohort, in which he and his group evaluated 1,400 patients, were affected with congenital heart disease. And the most common congenital heart disease we see are ventriculoseptal defect and tetralogy of Fallot. But we certainly also see more atypical lesions as well. In our cohort, we did see individuals who had HLHS and vascular ring, but we also saw the majority of our patients having more commonly described heart changes such as tetralogy, interrupted aortic arch, VSD, and truncus arteriosus. With the 22q diagnosis being associated with common heart changes like VSD, other researchers have thought about screening kind of all individuals with VSD for 22q. And we certainly feel that any individual with a structural heart change deserves a referral to genetics, or at least a conversation about screening for the condition. In looking at a series of many researchers who have evaluated the prenatal symptoms of 22q, almost all noted structural heart changes in nearly all of the patients that they took care of. We also looked to evaluate what do we know about the condition prenatally outside of structural heart disease. And in our group of 42 cases of confirmed 22q deletion syndrome, these were individuals who were diagnosed in one center, also delivered in that same center, so received prenatal and then pediatric care all within the same hospital system. And we noticed that extracardiac findings were noted in about 90% of the prenatal picture for all of these kids. And while it may not benefit to go through every structural change that we see, it's important to note that almost every body system can be affected with 22q, and also many of those body systems can show signs prenatally. So we saw a large majority of our patients showing differences in the central nervous system, mainly being that of something called a dilated cavum septum pellucidum, which can be measured prenatally. We had individuals with spina bifida, or individuals who had increase in the ventricle size for one of their ventricles within the brain.
A few studies have come out in looking in general at screening ultrasounds, and a standard measurement that we obtain on all second trimester ultrasound is a look at the cavum septum pellucidum. And in a large series, 2/3 of the fetuses affected with 22q deletion were noted to have an enlarged CSP in utero. And so this has been proposed as a possible marker for prenatal diagnosis. And what many families go through that has been described as the diagnostic odyssey of 22q is that what you'll see as we're going through these different markers on ultrasound is that there's not one specific finding that points us in the direction prenatally of making a diagnosis of 22q. So we kind of have to use all these various potential findings and determine whether or not we think that 22q at all is on the differential diagnosis for any given fetus.
To speak more to that, we've also seen individuals with gastrointestinal changes, most notably tracheoesophageal fistula, and we've had cases that have had this finding that have had congenital heart disease and have been isolated findings on their own. We've also seen many genitourinary differences, such as pilactocyst or increased size of the kidneys, or a difference in the appearance of the kidneys being multicystic or dysplastic.
This is what a normal fetal abdomen looks like here. This is the umbilical vein coming in, the spine is in the back, and then this is what a normal stomach bubble looks like. And typically when we see a fetus that has a tracheoesophageal fistula or a difference in the esophagus, the stomach may not appear normal in the fetal abdomen, and there may be increased fluid around the fetus, which should raise an eyebrow and lead us to a possibility of 22q deletion syndrome in the spectrum of the disorder. Another common view that is obtained on an ultrasound is a view at the level of the kidneys. And so again, the spine is in the back, this is the front of the fetal abdomen, and when we measure the area of the kidney known as the renal pelvis, this is where the urine collects before it goes down the ureter into the bladder. Sometimes this can be dilated, and it's a non-specific finding and can be associated with multiple genetic changes. And then this side, this kidney, you can kind of see has a lot of fluid in it, or blackness, and it's got all these various bubbles that kind of look, or dark areas that look like bubbles, and this is what's called a multicystic dysplastic kidney. And typically we don't think that this is associated with genetic changes, but it can be, and we've seen a handful of cases where this has been the only finding in a fetus that, as it turns out, is affected with 22q deletion syndrome. And here's another example that will show you just how different this can appear, but these are typical appearing kidneys here with the spine, and then here's another one of those multicystic dysplastic kidneys, but you can see how these bubbles or dark spots look very different than the previous imaging that we just saw.
We've also seen differences in the pulmonary system. Specifically, we've seen a handful of cases of congenital diaphragmatic hernia, And there have been reports in the pediatric literature that echo this, that say that diaphragmatic hernia with or without other findings can be associated with 22q. And so we should always be thinking about 22q when we see a fetus that's affected with a diaphragmatic hernia. We've also seen a case where the individual had a lung lesion, and while this is typically not thought to be associated with genetic changes, it has been associated in our cohort. Just thinking about that all babies with structural differences should be screened for a condition that is this common. We know that many of our families follow with a craniofacial team, or at least are aware of craniofacial differences that can occur within 22q. And many of the prenatal providers focus on cleft lip and cleft palate being a large ultrasound marker. And we know that in the pediatric cohort, this is something we can see, but the finding of those two things together is actually not that highly reported. And it was not that highly reported in the series of pregnancies that we followed. What was, however, more remarkable was the appearance of the ears in the babies that we scanned prenatally. And that many of those individuals had what we call hypoplastic or small ears, which were less than 10th percentile for gestational age. We've also seen differences in the chin being a little bit smaller, called micronaphia, eyes being a little bit closer, something called hypotelorism, and a difference within the nose where it has a more bulbous appearance that you can even appreciate prenatally. So just kind of always speaking to the fact that by doing profile or views of the face, you can sometimes get a sense of the symptoms that you may see postnatally in these kids.
Here's just a handful of ultrasounds. So here's a 2D image of a cleft lip here. This is the tip of the nose. This is the bottom lip here. And then here's the upper lip, and you can see this gap in between the two sides. And then here's a 3D image of a baby with a cleft lip, which is a little bit more apparent to see. And then when we measure the ears, we measure from the top of the ear to the bottom of the lobe. And for every gestation, there's a normative value for what the size of the ear should be. So we plot it against the weeks of gestation. We know whether or not the ears appear small for gestational age.
We've also seen differences in the spine where the vertebrae don't always align perfectly. We've seen cases where long bones or the limb bones measure a bit shorter than what we can anticipate or would predict for gestational age. We've seen cases of isolated clubbed feet, which we know is something that we describe postnatally. And we've seen differences with the chest. Specifically, we have one case where the chest kind of curved out like a bell shape, which has not previously been reported with 22q. We've also seen cases where we've had pregnancies affected with polyhydramnios or increased amniotic fluid, and sometimes that's secondary to a change like tracheoesophageal fistula, where the polyhydramnios or increased fluid is secondary to that finding, and sometimes it's idiopathic, meaning that we don't exactly know at this point why that happens. And we've also seen cases that have single umbilical artery, which can be a finding in the general population and can also be associated with birth changes.
Another potential marker that has been proposed to determine whether or not a fetus could be affected with 22q is looking at the size of the thymus. As we all know, these kids tend to have immune differences, and so whether or not the thymus measures small in the fetus has been proposed as one of these markers. And so in a view where we're looking at the vessels coming out of the heart, the thymus is right in front of the heart in the chest, and we can measure the distance across, and then we can also, in the same view, measure a front to back distance of the thymus compared to the rest of the chest. So this is a measurement through the fetal chest with the spine in the back. And some of the studies that have been reported out there is that the kids, or the fetuses I should say, who have 22q deletion syndrome with congenital heart disease have the smaller size in their thymus compared to kids that don't have 22q with heart disease.
And here we're just showing our paper in comparison to many of the other prenatal series to show that everyone comments on cardiac changes and knows that that's an important feature of 22q and something to look for when moms are pregnant. But some of the extracardiac or other body systems are less commented on or are less known about in the prenatal period. And while we went into a lot of detail about what the ultrasound findings are, I think one of the things that we hear often from our patients as they enter into the pediatric setting, or we hear from pediatric providers, is that our families have gone through, our families who have not received a diagnosis have gone through a long odyssey of having subtle features that they wish people could have put together sooner. And maybe if they did put together sooner, could have positively impacted their child's care. And so we go through all of these different body systems that you can appreciate prenatally just with the hope of increasing that awareness and education of these are things that we can look for and these are things we should be looking for to get the diagnosis as soon as possible to better the outcomes for our kids. One of the ways to get a diagnosis earlier is to do prenatal diagnostic testing. And so we talked about how in the first and early second trimester we can consider doing CVS testing for diagnostic testing. As we enter into the second trimester and later into the third trimester, we can consider prenatal diagnostic testing in the form of amniocentesis. And this is a procedure in which a doctor would remove amniotic fluid, usually 1 or 2 teaspoons of amniotic fluid from the amniotic fluid cavity to test baby's DNA. And that amniotic fluid is rich with different types of prenatal DNA. And it's one of our only ways to really access baby's genetic information before baby is born. You can do this as a form of just genetic testing. So if we saw any of these features, this would be an option. And sometimes if individuals do have polyhydramnios or a lot of excess amniotic fluid, this can actually be a treatment where doctors will remove some of that fluid in order to reduce the risk for preterm delivery for individuals with polyhydramnios. There are other fetal indications that may also require or be offered amniocentesis as a treatment option. The risks with amniocentesis, just like with CVS, are somewhat center dependent. Those risks include leakage of amniotic fluid and premature birth between 0.1 and 0.3%, depending on center and experience, as well as infection. The best test once an amniocentesis is performed is a microarray. And a microarray is the best way to detect 22q, pre or postnatally. And that is because some of the other tests that you can do for 22q, specifically FISH, which offers a faster turnaround time of 2 to 3 days, as opposed to a microarray, which is about 14 days or sometimes longer, is that you will pick up not only the more common deletions, which are the A to D deletions, which we know about 85% of our kids are affected with, but you'll also pick up the atypical or nested deletions, which about 10 to 20% of our kids are affected with. We know sometimes with those nested deletions, particularly C to D and B to C deletions, which are just different areas within 22q, they have a little bit more higher familial rate or are more associated with being inherited versus being new in the individual. And that certainly can change recurrence risk. It can also alert your medical providers to test other members of the family who may have atypical presentations. Currently, there are no known genotype-phenotype correlations. And what this means is that one deletion size or deletion area is not associated with a different set of symptoms. We still view 22q as a wide range of spectrum of condition that has kind of all of the symptoms that we all know about. where some kids have more symptoms and some kids have less symptoms, and it's hard to predict which individuals will have more or less. We do know that there are genes specifically in different places of chromosome 22 that are important in different areas of the body. So one of which being the TBX1 gene, which is important in cardiac development, and one being the CRKL gene, which is important in renal development. And so we have had individuals with smaller deletions between the C to D region who don't have heart changes but who do have kidney changes. And so you can see that if you did a test like a microarray, it would detect all of that. Whereas if you only did a FISH test, you would miss those individuals who had smaller deletions and maybe only had renal findings, which would continue a family's diagnostic odyssey. We also know that because this is a common condition, individuals can be affected with 22q and another condition. And so if it is thought that 22q may not explain all of the symptoms for a pregnancy or for an individual, that maybe further testing or further evaluation with a geneticist may be needed. So the presence of 22q does not exclude another diagnosis. We have to always be considering the entire picture. For providers, it's important to know that microarray remains the most appropriate test. And as patients, sometimes we have to educate those providers in what we mean, just meaning this is the most comprehensive test we know available. That being said, we've also had patients who have had normal microarrays but still exhibit the symptoms of 22q. And in those cases, another test to consider is sequencing of TBX1. And this is for patients who fit the symptoms of 22q but have had negative microarrays. You can do sequencing or a spell check of this TBX1 gene, which we talked about being important in heart development, and that sequencing might yield a diagnosis.
As many of you know, there are advantages of making an early diagnosis, particularly prenatally. One is that it can help the family prepare mentally and from a psychosocial aspect for delivering a child that is going to need a larger care team. We can also improve planning for the birth when we have a diagnosis prenatally. Sometimes this might mean changing from a community hospital to an academic hospital or a larger hospital with a larger NICU or a higher level NICU, and the availability of a multidisciplinary team to take care of the newborn. For example, a baby that might need cardiac specialists or genetic specialists or immune therapists, endocrine specialists, those sorts of things, as we know that these are common issues that these kids deal with in the newborn period. As of now, there is no standard pregnancy management plan for a woman who's carrying a baby affected with 22q. A lot of it, centers around routine prenatal care for mom. Because we know these kids tend to grow, not optimally after they're born, we still worry that maybe prenatally they will develop growth restriction. And what we tend to see is that they don't meet the criteria for technical growth restriction, but their growth velocity slows and they gain less weight as the pregnancy goes on. And so what we recommend is serial ultrasounds throughout the pregnancy to monitor the overall growth of the baby when a confirmed diagnosis has been made in a pregnancy with 22q. At the time that we're monitoring the growth of the fetus, we're also monitoring the amniotic fluid, looking for any development of polyhydramnios or increased amniotic fluid, because we know that this could potentially negatively impact the pregnancy. Too much amniotic fluid is a risk factor for preterm labor and early delivery. It can also result in the baby more likely to be malpresentation, meaning breech or transverse, and mom needing a C-section at the time of delivery. And then also, if there's significant polyhydramnios, mom can have a lot of symptoms related to this, such as shortness of breath, difficulty doing exercise, shortness of breath, walking around the house, difficulty sleeping, difficulty eating, those sorts of things. And then if there are any structural differences identified in the baby, we monitor the pregnancy more closely for changes that we might see on ultrasound. For example, serial ultrasounds to monitor the cardiac function of the baby. If the baby is known to have heart disease, if there's any differences in the kidneys, we'll follow the pregnancy more closely to make sure that the amniotic fluid and the kidney function remains normal. If there's any dilation of the ventricles in the brain, to monitor to make sure that there's not worsening of the ventriculomegaly. And then making sure that we're optimally planning for the time of delivery and making sure that the care team is available for the newborn right after delivery. Sometimes that means parents meeting with multiple subspecialists to optimally plan for the newborn shortly after delivery, planning the delivery location. And because of concerns that a lot of these babies see with eating, meeting with the lactation specialist to talk about breastfeeding options, bottle feeding options, and potentially speech therapy for these babies. There's not a lot of data out there with regards to what happens in pregnancies when the fetus is affected with 22q. Of the 42 pregnancies that were diagnosed, followed, and delivered by us, we did not have any episodes of stillbirth. Most of the babies delivered at full term, just under 39 weeks. Most babies weighed about 6.5 to 7 pounds. Some were a little bit bigger, some were smaller. 2/3 of the moms delivered vaginally, and about 1/3 required a cesarean delivery. And those were really mixed indications for the cesarean delivery. Of the women who it was their first time having a C-section, the indications, some of them were because of, failing to dilate or obstetric indications. Some had to do with maternal indications, and some had to deal with fetal intolerance of labor or the baby not tolerating labor. So it was really a mixed bag as to why moms needed to have a C-section. We're also probably seeing more 22q deletion in miscarriage samples than we had ever thought before. So another thing I think it's important for providers to be aware of and for us to advocate is that for a care provider who's seeing a woman with multiple miscarriages or even a miscarriage is to offer testing on the miscarriage sample to determine whether or not there is not only just possible chromosome changes, but is there any evidence on the microarray that 22q deletion might have been associated with it. For men and women who have 22q deletion and are considering becoming pregnant or parenting a pregnancy, there really is very little data available outside of knowing what recurrence risk potentially is for someone who is themselves affected. But one of the key and important aspects of this, just like with any woman who's entering a pregnancy that has a chronic medical condition, is that we're optimizing any of the medical issues that can be associated with 22q. For example, a woman who is entering a pregnancy with heart disease, we need to make sure that we're optimizing it. A woman who has thyroid disorder, immune disorder, any kind of endocrine disorder, is to optimize her care before she becomes pregnant. And then making sure that individuals who may have poor impulse control or inadequate social support are practicing safe sexual practices and making sure that they're protecting themselves and getting all the support that they need, and seeing providers and getting genetic counseling in a timely fashion. We kind of just talked about many of these aspects, but many of the psychiatric concerns that we see in individuals with 22q can negatively impact the pregnancy and the outcome for the newborn if they're not optimally managed ahead of time. And so women who have psychosocial differences and who have psychiatric disease in and around the time of the pregnancy and at the time of delivery, it can not only impact maternal outcomes, but it can also impact how they care for the newborn and how that child develops over infancy and into school age. And so these individuals really need a multidisciplinary team to optimize their care long term. In the limited data that is available for women who themselves have a diagnosis of 22q, there were 21 women in a series that had a total of 58 pregnancies. Of those, 13 resulted in miscarriage, and 6 women opted to terminate pregnancies. Of those who opted to continue the pregnancy, 95% of the babies were live-born, and 2 were stillbirths. And this is about a 5% risk for stillbirth, which is higher than the risk for stillbirth in the general population. And so clearly in women who are deleted themselves should probably have closer surveillance in the pregnancy and see a high-risk specialist throughout their pregnancy. On average, those 37 live births, about a third of them were small for gestational age, and this was much more likely if the fetus was also affected with 22q. The majority of moms had a vaginal delivery, with only 30% requiring a C-section, and most of the pregnancies, 84%, delivered at term. And so these are very typical outcomes as what we standardly see in the general population, except for the small for gestational age tends to be more common, particularly if the fetus also has 22q. So in general, pregnancy in women who have 22q and become pregnant themselves, and for pregnancies affected with 22q, we don't know a whole lot about how to optimize the care for the pregnancy or what the typical history is throughout the course of the pregnancy. And so there's a lot of work that needs to be done. We really need to study this population. We need to have better markers. We need to know how to better educate the medical community and parents who are expecting pregnancies with 22q in order to come up with the best pregnancy management plans, not only for women who are affected, but also to optimize pregnancies where the fetus is affected.
Thank you, Julie and Erica.